Good evening, everyone. Welcome to tonight's teaching session, which is being jointly organised with our friends and colleagues at Orthopaedic Research UK and the Orthopaedic Academy. So, I'm David Hughes. I'm one of the conveners today for your session. I'm with the great pleasure of introducing our guest speaker, which is Miss Deepa Bose, a consultant orthopaedic trauma and limb reconstruction surgeon at Queen Elizabeth Hospital, Birmingham. Her practice is generally exclusively adults and includes general trauma, major trauma, post-traumatic limb reconstruction, osteomyelitis, malunion, non-union, limb lengthening, and deformity correction. Today, the talk is going to be on the very important part of orthopedics, which is going to be centered around for the FRCS level, but also for hopefully you'll take key messages on for your future career, because it's about the management of fracture-related infections. This is something hopefully you'll never have to encounter in your career, but if you do, you need to know how to deal with it and also how to approach it for the exam-based questions. And it is beholden on all of us as duty of care to our patients to try and avoid infection as best as we can. But when it does unfortunately happen, we need to know what we're doing. I'm also kindly joined today by Rajesh Gopreddy, one other colleague from the Orthopaedic Academy, who afterwards will go through some Viva questions. So just to run through the program again, so we're going to start, you've had our introduction. We're going to start very soon with the talk from Dr. Bose. We'll have a few MCQ questions and invited questions from the audience. So during the talk, I would ask you to put all the questions you'd like to ask in the chat box, and then I'll pass them on to Dr. Bose at the end. And then we'll have a few willing victims for our hot seat Viva practice. The questions won't just be related to infection; they will be from as much as we can from the curriculum. And then we'll have a finish and we'll close. Now, just quickly before we go on to the next bit, onto the talk, just to let you know about a few upcoming Viva courses. We have one in September on 9th and Saturday, October 14th, and Saturday, December 2nd. These are all fantastic preparation. It's a very intense course, but fantastic preparation for the exam. So if you want to, please do sign up. There's a QRS code on the screen, so you can use that as a direct link with more information on the OR UK website. All right, so I think you've had enough from me. Without further ado, we'll go on to our main talk, and I'll hand you over to Dr. Bose.
Thanks very much for asking me. It's a great pleasure to be here, and I hope that by the end of the talk, you'll have some idea of a constructive way of approaching fracture-related infection. So we'll start with why is bone infection a problem? So if you look at the literature, fracture-related infection, the incidence varies widely depending on which paper you read. And there are obviously factors that predispose to it. So for example, it depends on the injury site and complexity, the number of previous surgeries, comorbidities of the patient, and it is known to be common after open fractures and fixation. So why is it such a problem? And as we mentioned, even though you don't treat it, you need to know what to do with it. So I'm going to introduce you to the concept of the orthopedic ostrich, and I'll explain a bit more about that as we go along. But bone infection is difficult and a problem because it's difficult to diagnose and it's difficult to treat. So we'll take each of those in turn and see why that is. So first of all, let's look at why it's difficult to diagnose. So with the photograph on the left-hand side of the screen, you can see that that's fairly obviously infected. There is a sinus, which is draining pus, and there's surrounding erythema and cellulitis of the skin. But if you look at the postoperative wound on the right-hand side of the screen, you can see that actually there's just a little bit of redness. There's a little bit of discharge staining the steri-strips, and you don't know whether that's infected or not. So if you're an orthopedic ostrich, you may say, well, that's not infected, but we know that the surgical wound leads straight down to the surgical implant. It's directly connected. So as far as we're concerned, there's no such thing as a superficial infection in the presence of underlying metalwork. You have to have a high index of suspicion, and you have to think that this is potentially infected. So if you can't rely on the clinical picture, then what else do we have to help us make a diagnosis? Well, what about blood tests? Well, we know that in the presence of implant-related infection, all of our normal inflammatory markers, like the white cell count, neutrophil count, ESR, and CRP, they may all be completely normal in an implant-related infection, unless it's a very severe infection. So although you may do bloods, they may not be that helpful in diagnosing an FRI. So if you can't rely on bloods, then what else do we have? So negative laboratory results don't equate to the absence of infection. So don't be fooled, like an orthopedic ostrich, into thinking that just because your bloods are normal, there's no infection. So what about imaging? So I'll just talk to you briefly about the nomenclature that we use when we talk about infection. So if you look at the image on the left-hand side of the screen, you'll see that there are several arrows pointing to important structures. So the old dead cortex is referred to as the sequestrum. And you can see that it is encased by new bone, which is called the involucrum. There's a hole in the involucrum, which is called the cloaca. And this is where the discharge and bits of dead bone will come out from. Now, the hole in the skin is called the sinus. So don't confuse the two. The hole in the skin, the sinus, communicates with the hole in the bone, which is the cloaca. So that's just some common terminology for you to be familiar with. Okay, so when we talk about diagnosing infection using imaging, we have various types of imaging. So there are anatomical imaging techniques like CT scans and MRI. So these are not dynamic, they're static imaging, and they just show us the anatomy. And sometimes that can be helpful. But when you've got an implant in place, then an MRI may not be particularly useful. Other types of imaging are functional. So like isotope bone scans or white cell label scans, these show you what is happening at the functional level. And then there are combination scans like SPECT scans or PET scans, which are a combination of anatomy and function. And these are a bit more useful when it comes to diagnosing infection, but none of them are entirely conclusive on their own. So if you can't rely on imaging, then what about microbiology? Well, the first thing to say about microbiology is that surface swabs are not helpful at all. Because as you know, we all have bugs on our skin, and a surface swab will pick up skin commensals. And those aren't necessarily representative of the organism that is causing a deep infection. So surface swabs are not particularly useful. I don't use them at all. I haven't used them for about 14 years. Really what you want to diagnose an infection is tissue samples. And the best tissue samples are clean samples taken with clean instruments. So when I say clean, I mean samples that haven't touched the skin or any other contaminating tissue. And you want multiple clean samples taken with clean instruments or one clean image-guided biopsy. And they need to be plated up as soon as possible. So the reason for that is that dead organisms will not form a culture. So if you take a sample and you send it down to the lab, let's say you take your sample on Friday afternoon and you send it down to the lab. By Monday, it will be a desiccated shred of tissue and all the bugs inside will be dead. And so you will never grow anything from it in a culture. So dead organisms will not form a culture. So you need living organisms, which is why they need to be plated up. Your transfer time to the lab needs to be as short as possible, and they need to be plated up as soon as possible. So if I take a sample, I will normally just call the lab and say, I'm getting a porter to take these down to you now. Can you plate them up as soon as possible? The other reasons why you may not get growth are if you have fastidious organisms that don't form a culture, or The other problem you may have is that you may grow something that isn't the causative organism, such as I've said, if you've contaminated it by swabbing the skin. And there are other methods like, apart from culture, there are other methods like PCR. So that doesn't rely on having a living organism. Even if you have dead organisms, it will identify the organism. But the problem there is that it doesn't give you the sensitivities. You need a living culture to get sensitivities. So culture negative doesn't mean that there's no infection. It simply means that you haven't identified the organism. And your chance of identifying the organism is only as good as two things: how you take the sample and how you process it. So you just have to be quite careful in how you harvest sample and how you process it by limiting the possibility for cross-contamination. So as you can see, there isn't a single way to diagnose fracture-related infection. It is a cumulative diagnosis. And there are some confirmatory criteria for bone infection, which have been put together by the consensus group on fracture-related infection, who have published extensively on the topic. And I recommend that you read their papers. So the confirmatory criteria are as follows. So if you have a fistula, a sinus, or a wound breakdown, which is directly communicating with the bone or the implant, which is why I've said that if you have a wound that looks a bit suspicious, you have to assume that it's infected. Purulent drainage from the wound or the presence of pus next to the implant during surgery. Phenotypically indistinguishable pathogens from at least 2 separate tissue samples. So we try to take at least 5 tissue samples when we're sending off for microbiology. That's the minimum that I would take. And then microorganisms in deep tissue as confirmed by histology. So whenever you're sending samples for fracture-related infection or for any bone infection, you should send samples not only for microbiology, but also for histology, because it could be that if you get a culture negative infection, which we often do, so about 20% of fracture-related infection turns out to be culture negative, meaning that we fail to grow anything, then the histology will give you the answer. So those are your confirmatory criteria for bone infection. Okay. So I've said that it's not only difficult to diagnose, but it's difficult to treat. And these are the reasons why. You get formation of a biofilm over the surface of implants. The infection is usually not accessible to antibiotics. You have to manage your dead space quite differently from how you would manage it in a soft tissue infection. And it is often associated with instability of bone and a lack of vascularity. And so unless you address each of these things, your treatment plan will be doomed to failure. And so we'll look at each of these things. But first of all, let's look at the management paradigms. So whenever you think of a patient with bone infection, what are your treatment options? Well, these are your treatment options. So you could do nothing. It is possible for patients to live with a mild form of infection. Or you could choose to suppress your infection. But if you're going to do that, then you need some form of biopsy so that you can direct your antibiotics according to the culture. And these are the management strategies that we would use for a poor host. So for type C patients who have multiple comorbidities, who are not able to withstand prolonged surgical management or big complex surgery, then you would choose either of these 2 treatment strategies. However, if you have patients who are able to withstand big complex surgery, then you can do either of these 2. So you can look to eradicate the infection, but keep the limb, so limb salvage, or you could do an amputation depending upon a multitude of factors. But essentially, these are the 4 management strategies that you can use to treat bone infection. So watchful neglect, suppression, limb salvage, or amputation. And what you choose depends upon a very complex interplay of factors. And so a multidisciplinary approach is crucial when you're managing fracture-related infection, because you have patient factors such as the patient's comorbidities, general fitness, smoking, alcohol, and their wishes. And then you have your injury factors such as, do you have bone loss, soft tissue loss, are the joints affected, is the vascularity affected? So there's a very complex interplay between all of these factors, which will determine which of those management paradigms you and your patient feel is best for them. And the patient is obviously central to your decision making. Okay, so we'll move on to talk about limb salvage now, because most of our patients that we treat surgically will end up with limb salvage. And so what do we have to do to manage fracture-related infection if you want to save the limb, if that is your goal? So you need to optimize your patient, because you can do all kinds of clever surgery, but unless you've optimized your patient, whatever you do is doomed to failure. You then have to treat your infection, and you do this by dealing with the biofilm, dealing with the dead space, and then providing appropriate antibiotics. And then you encourage fracture healing. And how do you do that? By providing stable fixation, good soft tissue, and good vascularity. So we will look at each of those things in turn. So optimizing your patient. So we know that smokers have a threefold increased risk of getting a bone infection or a non-union compared to the normal population. So our aim is usually to get the patient to stop smoking, certainly in the perioperative period. Treating diabetes and other comorbid conditions which will increase the risk of infection and non-union. Managing immunocompromised patients. We try to stop antibiotics at least 2 weeks prior to debridement for the reasons that I've mentioned, because when you take samples, you want to culture a living organism. So your chance of getting a living organism is much better if you've stopped your antibiotics prior to debridement. And then we used to say that we would stop nonsteroidals because nonsteroidals were thought to be deleterious to bone healing. But the most recent studies show that this isn't such a problem as we used to think. And so for my patients, I don't mind if they have one-off nonsteroidals for breakthrough pain, but I still try not to use it regularly. So as I've mentioned, there are certain precautions that you have to take when you're taking your samples. So we use separate clean instruments for each sample. Take care not to touch the skin because you don't want contamination. I put the samples straight into the container, so I don't put them in a swab and leave them lying around for the scrub nurse to put into the container. I put them straight into the container because the number of times that you transfer your sample just increases the risk of cross-contamination. I take 5 for microbiology and 1 or 2 for histology. And then we start empirical antibiotics in theatre. We usually use vancomycin and meropenem because that combination will actually take care of most of the gram positives and gram negatives that we see in fracture-related infection. And then, as I've said, I usually call down to the lab and ask them to plate it up the same day so that there's less risk of cross-contamination and more chance of growing a living organism. Now we talk about debridement, and radical debridement is really important because you have to get rid of your biofilm. So if your implant is stable and you're early into the infection, say within the first 3 weeks, then you can consider a DARE. That is debridement and implant retention, just like you do in prosthetic joint infection. So if you've got early days, stable implant, no deformity, no loosening, then you can consider a DARE. However, if your implant is loose or you've got established infection, then you have to remove the implant and carry out a radical debridement. Radical debridement means removing your implant and excising all the dead bone. You want to see in cortical bone, you want to see what we call the paprika sign, which is pulsing. In cancellous bone, that will bleed readily, but in cortical bone, it doesn't bleed readily. You just know that it's a lot. And then you have to be fairly radical if you are expecting to control the infection. So we've talked about improving the response to antibiotics, and we'll discuss here about removing the biofilm. So you know that the biofilm coats any dead material. So that refers to implants or dead bone. And it's a surface phenomenon. So it means that there are bacteria or microorganisms living in a very low metabolic state on the surface of either dead bone or implants. And unless you remove this completely, you will not be successful in controlling your infection, because antibiotics are not able to reach these microorganisms inside the biofilm. So if you want to eradicate the biofilm, you have to remove all implants and dead material. And if you look at the picture on the right-hand side of the screen, what it's showing you is the footprint of a plate. So the footprint is the bit of bone that's been covered by the implant. And you can see that if you have a plate, you have to be fairly radical in removing any part of the bone that was in contact with the undersurface of the plate. Another way to improve the response to antibiotics is to use local antibiotic delivery systems. So there are many preparations on the market that you can use, like Osteomyelitis or like Cerament, that will release local antibiotics into the area, which improves the response to antibiotics. And then you can also improve the delivery of systemic antibiotics by increasing the vascularity into the area. So for example, if you do a free flap with our plastic surgery colleagues, that improves the vascularity, and that therefore improves the delivery of systemic antibiotics. Now, I've talked about the dead space. What is dead space? So dead space is the cavity or the space that is left behind after you've done your debridement. Now, in a soft tissue infection, like let us say a breast abscess, the walls of the cavity are soft. So if you were to put a suction drain into the cavity, the walls of the cavity will collapse upon themselves and you no longer will have a dead space. However, in bone, the walls of the infected cavity are rigid because they comprise of bone or fascia, both of which are quite rigid. And so the cavity does not collapse upon itself after debridement. And what will happen is if you've done a thorough debridement, there will be bleeding from the walls of the cavity, and the cavity will fill with blood. And as we all know, blood is an excellent culture medium. So you have to get rid of the dead space if you want to prevent recurrence. And so ideally you would fill your dead space with something which is also a local antibiotic carrier. So I've mentioned there are many preparations in the market like Osteomyelitis or Cerament that will fill the dead space and release antibiotics at the same time. However, often those preparations remain behind and don't necessarily get incorporated. And so the ideal dead space filler still eludes us. Now, the other problem you may have is dealing with bone loss or bone instability. Generally speaking, in infected cases, we prefer external fixation. Now, there are places that external fixation may not be appropriate, for example, around the hip or the pelvis, where it's difficult to control fractures. And so in those instances, you may still have to use internal fixation. But generally speaking, we prefer external fixation. Why? Because it provides stable fixation, because generally speaking, the pins and the fine wires that are used in external fixators provide a minimal surface area for biofilm formation. So it's not impossible for them to get infected, but it is less likely compared to using internal fixation. It also has other advantages, so it will allow you to correct a deformity and to recreate lost bone by using methods such as distraction osteogenesis. So for those reasons, we prefer generally external fixation. What about soft tissues? You can often have instability of the soft tissues or soft tissue defects that are associated with fracture-related infection. So there are advantages to providing robust soft tissue cover or vascularized soft tissue cover. So first of all, it provides cover, so it means that your bone is not exposed to the exterior. But it also provides vascularity. As I've said, if you're doing free tissue transfer, then that brings with it its own blood supply. And so it improves the vascularity to the area. It increases antibiotic delivery because systemic antibiotics will only go as far as the blood supply can take it. So if you have better blood supply, then systemic antibiotics will reach the area of interest. And then finally, there is some evidence to show that vascularized tissue, especially muscle, provides undifferentiated mesenchymal stem cells, which can be recruited into the fracture healing process. So there are certain advantages to providing robust soft tissue cover. And please note, you can't do this with a skin graft. It has to be vascularized tissue. So there are several publications, as I've mentioned, relating to fracture-related infections. Particularly for those of you coming up to the exam, you need to know all the boasts, and there is now a boast on FRI, so please make sure that you're familiar with it. I've said that there is a consensus group on fracture-related infections, and they've brought out several publications. There are a suite of perhaps 6 or 8 publications from the consensus group, and they are really helpful in understanding how to diagnose and how to manage fracture-related infections. So if you're interested, do read them, but definitely for the exam people, you must know the boast. Now that you all know everything about fracture-related infections, I hope that you'll find the MCQs reasonably straightforward. But let's look at this. So we'll start with this case. So this is a 41-year-old male polytrauma patient with multiple fractures, but this question relates to his humeral fracture. So he had this fixed internally, and he presents 4 months after his surgery with a sinus discharging frank pus along the incision line. His general health is otherwise good, and the x-rays are as you see there. Let's talk through the answers. So take a swab and wait for the results. So as I mentioned in the talk, surface swabs aren't particularly helpful in this situation. So A isn't the answer. B is request an isotope bone scan and plan for surgery. Well, there's really no need for an isotope bone scan in this situation because you have a patient who's discharging frank pus. And you can see that the x-rays show you that you have a loose implant with a displaced fracture. So essentially, that is your diagnosis. You don't particularly need a scan to tell you that it's infected. So B isn't the answer. C is plan for surgery and stabilize the bone with an external fixator. And that's an entirely reasonable option because you know that you're going to have to do something about it. So you're going to have to debride, remove your implant, and then stabilize the bone because unstable fractures will never heal. So you have to stabilize it. And as I've mentioned, our preferred method, if possible, is external fixation. Recommend a staged endoprosthesis. Well, if you had a different patient with a different fracture, you might do that, and that may be a perfectly reasonable option. But in this case, you've got a patient who's relatively fit and well and has good bone. So actually, there's no reason to suppose that if you didn't treat it properly, it wouldn't heal. So the answer is C. Thank you. Okay, so we're going to move on to the next question. A 47-year-old male smoker, cigarettes and cannabis, had a closed distal tibial fracture. and he was treated with open reduction and internal fixation. So the first post-operative X-ray is the X-ray that you can see on the left-hand side. But his wound never healed properly, and he presented 6 months post-operatively with discharge from the wound and sudden pain and inability to weight bear. Okay, so you've left with a big bone defect and a big soft tissue defect. Now, you can stabilize with internal fixation and fill the defect with a fibular graft. But if you allow the soft tissues to heal by granulation and split skin grafting, then you haven't got robust vascular soft tissue cover. And so, as I've said, that will simply allow reinfection to occur. You could advise amputation because you've got significant bone and soft tissue loss. And actually, that should always be considered in this situation. So if you've got a host who isn't the best host, and you have got significant bone and soft tissue defect, then you should always mention amputation as an option. So B isn't wrong. B is a perfectly reasonable option. Shorten acutely and close the soft tissues. Well, you could do that if you had a host who was really had multiple comorbidities and wasn't able to withstand a big reconstructive surgery, then that would also be reasonable. But despite the fact that this man is a smoker, he's not the fittest person, he's still ambulant, he's still walking. So if you shorten him quite a lot, then that would be a problem because it would affect his mobility. So C wouldn't be what I would choose. And D, you do what we have just talked about in limb salvage. So you do a radical debridement, you do destruction osteogenesis to fill the gap, and then you use a free flap to fill the soft tissue and to provide vascularity. And that is an entirely reasonable option in this patient because although he's not the best host, he's actually not too bad. So we went for option D. So that is what we would choose as our answer. But if you've chosen B, that is also a reasonable option. Okay, so we'll move on to our final question. And now this is a 59-year-old female patient. She has multiple comorbidities. She has diabetic neuropathy and nephropathy. She has pulmonary hypertension, ischemic heart disease, previous stents, and her mobility is normally poor prior to her injury. So she had a low energy fall resulting in a distal femoral fracture, which was fixed as you see. 6 weeks later, she has discharge from the wounds. She underwent an initial debridement and the metalwork was removed because it was loose and falling off. Bone quality was found to be very poor. Most of her lateral condyle had to be thrown away because it was dead. So she has now lost bone and a bit of soft tissue. So if you look at your options and see what you think would be the best thing to do. So a staged distal femoral replacement. Now, yes, if you had a better host, if you had someone who was ambulant normally with good mobility, then you could choose to do a staged distal femoral replacement. So that's not wrong, but you have to consider the patient. And in this patient, it wouldn't have been appropriate. And she wouldn't have been able to withstand having 2 operations 3 months apart. An above knee amputation is a reasonable option in this patient because it gets rid of the problem with 1 operation. Staged masculae with internal fixation is probably the least favored option here because putting more internal fixation in wouldn't work. First of all, you don't have much distal femur left. And secondly, further internal fixation is a bad idea in the presence of infection. And then again, definitive external fixation, this patient would not have been able to tolerate it. And there isn't much distal femur left to salvage. So A and B are both reasonable options in this case, but because of the patient, B is the option that we choose in this case because of the patient.